Well, hi everybody. I'm Dr. Michael Miyasaki, and I'm really excited about today's interview. We have Dr. David Alleman, who is a pioneer. I'm saying a pioneer, but he's been doing this for a long time. In biomimetic restorative dentistry, and I think it's a really important part. And I didn't even get to share this with you yet, but my feeling too is I was with a group of KOLs just this weekend, and we were going around this little round table, and they wanted us to say something that we believe in that's contradictory to everyday dentistry. And when they got to me, I said, my contradiction is that I think we as dentists are over treating our patients, from both the diagnostic point of view and then what we do. I said, if a patient has a big cavity, then what do we try to do? We try to do that crown for that tooth. But is there a more conservative way? Because we're not trying to take that tooth down that tooth cycle of restoration, crown, endo, extraction, and implant, right? So anyway, today we have Dr. Alleman, who practices in Provo, Utah with his son. And it's a family-run business, which I really like because it's how I run my business. But what we're going to talk about today is this philosophy of biomimetic restorative dentistry. And then we're going to get more into Dr. Alleman himself, which I find super fascinating. And then we're going to talk about why this is what all of us as restorative dentists have to understand. And I think it's a mindset on how we approach our patients and their care. Because, if my family member came in and they had an area of decay, I'm not thinking crown. I'm thinking, okay, how can I restore this as conservatively as possible? So, Dr. Alleman, welcome. Why don't we start off with why biomimetic restorative dentistry is so near and dear to you, and then we'll go back and learn more about just you and how you work.
Well, first, I've got to give some history because Mike and I go way back, and our experiences with the best of the best in adhesive dentistry go back 20, even 30 years. But these experiences have to be brought on to the next generation. And the successes that Mike has had, the success I've had, the companies that we've dealt with, these are all part of the history that you, as younger dentists, don't need to make the same mistakes that we all made. You can start where we're starting, which is at the apex. Hey, I like that
Yeah,
name.
yeah, yeah.
If we start at the apex, then we're standing on the shoulders of giants. And if we see farther, it's because we have benefited from those who have gone before us. And Mike and I are. I'm a little older, about 75. I think Mike's more 65-ish. But the idea is that every generation has to decide how dentistry is going to be promoted and taught. And personally, I've visited 60 dental schools in my career, 35 of them here in the United States and another 20, 25 overseas. And these dental schools, they start with students that are bright
Hmm.
and maybe smarter than we ever were. But the idea is that a dental student knows nothing about how to fix a tooth. And if you are a dental student, you assume that what you're going to learn in dental school is the best. But unfortunately, it's so conservative that the best of 25 years ago is not the best of now. And the best of 50 years ago really is not what you could be doing. And so the vision of Apex Dental and the Alleman Center is to have how should we say this? A revolution in dentistry, and it's already happened. So we don't want you to be the last people to find out about the revolution because in 8 dental schools that I personally have helped, they are teaching biomimetic restorative dentistry. And in any educational situation, it always starts with one faculty member who says, I know this is a possibility, but then it has to go through levels. It has to get to that clinical level, then it has to go to the administrative level. But these levels of student to faculty to administrators, what can we say, Mike? It's political.
Yeah.
And each dental school is a business. They've got to figure out. They want to make sure that they're not doing something that is going to be worse than they did before, but they're so conservative that they're not very fast in moving forward. But that has all changed, particularly in the last 10 years. And I'm associated with a vast network of dental scientists who have published a vast amount of dental research. Behind me, I have about 3,000 articles with my notes on that I've gone through since I was introduced to dental literature in 1995 by Ray Bertolotti, a common mentor that Mike and I have both had. And
Mhm.
when Ray Bertolotti gave me my first bibliography of 25 articles, I knew exactly what to do with it because I loved history. And I got the articles and started reading. And as they say, the rest is history. 30 years later, my wife still sees me reading things that she doesn't have any interest in, but she likes it when I fix her teeth that way.
Yeah. So what is the core biomimetic
Let's just say two things,
yeah.
and this is very important. If you want to do dentistry, the first thing you have to try to do is prevent endo. Now, endodontists love endo. But we have trained dozens of endodontists around the world who don't do endo when the tooth is referred as an irreversible pulpitis, and the dentist doesn't know what to do with it, and so he refers the endodontist, and the percentage of teeth that are diagnosed as irreversible pulpitis, once a endodontist is trained in biomimetic dentistry, that diagnosis disappears.
Hmm.
The only time you know that a pulp can't help you is when there's no response and you have a periapical lesion and you have a little pain to percussion. In that situation, endo is your friend. We don't believe that endo is worse than extraction implant, and we have the data to show that. But right now, how many companies, Mike, sell implants? I
Mhm.
mean, a lot. I
Hundreds.
heard once that there were 100 manufacturing companies that are making dental implants around the world and selling them. And so the dentist is the idea that, oh, the future is endodontics. Well, it's not. We
Mhm.
can save teeth and we can prevent endo what. So that's the first person. And then the second portion is to be more conservative of the tooth structure, which was the main principle of a movement that started 30, maybe even 40 years ago with minimally invasive dentistry. And one of the big pioneers of that was a good friend of mine, still alive, Tim Rainey. But the idea of minimally invasive preparations that can save a lot of tooth structure with these deep cavities or deep decay or a deep crack, this is not minimally invasive dentistry, but the conservative element is the conservation of what we call critical tooth structure. And the definition that we're going to teach you right now is the critical part of a tooth is not the top, it's the bottom. So the bottom half of the tooth, below the height of contour, that's where stress distribution comes into play. And a natural tooth has stress distribution in the tooth and in the PDL. Once you do endo or extract a tooth, you're never going to gain that kind of stress distribution from an implant. It doesn't have a PDL. Or from a crown with a root canal treatment, it doesn't have the hydration. And so that critical tooth structure, the pulp, and then the bottom half of the tooth, it gets hydrated by the pulp, and all of a sudden the tooth has flexibility. You can prevent that, but you got to stop doing full crown preparations. And so the full crown preparation, which I mean, there was a key opinion leader 50 years ago, made a lot of money. He was teaching the 90-second crown prep.
Mhm.
And Mike is shaking his head because he knows I talk. I'm not going to name the name, but I know that once I stopped doing crowns, which was 2 years after I met Ray Berlotti. So from 1995, 1997, I still did crowns. But by 1997, 1998, I had enough technology with caries detecting dye and better bonding systems. And I was introduced to the concept of C factor by Ray Bertolotti. And
Mhm.
all of a sudden, those three that are the foundation of the system that we teach, which is called 6 lessons, but the first 3 lessons, once you understand those, and I did in 1998 and stopped doing crowns in 1998, all of a sudden everything got better. Less sensitivity, less endo, no crown preps, less tooth loss, and every year since 1998, the results have been the same. I did the testing of my system for 5 years in my own office, and that period from 1998 to 2003, then I had it figured out and I had interest, and so I started to sell the teaching program, and doctors bought it, and when they bought it, they did it, and then when they did it, they told me how it worked, and all of a sudden we have feedback, but that feedback is using materials. And
Hmm.
Apex, for example, how many companies have you worked for in your career, Mike?
A dozen companies
A
for
dozen
sure.
companies that actually make the materials. I
Hmm.
cannot make materials. I
Yeah.
have no skill in advanced chemistry to create, but then to actually manufacture, that's a whole skill level. When you go to Ultradent, for example, which is only 5 minutes from my house, and you see the manufacturing and the engineers that had to figure out every machine, it boggles my mind. And
Hmm.
I'm humbled because I'm nothing without the engineers, I'm nothing without the chemists. But again, they can help us with the products. But again, it's how we do the dentistry, which is how we apply the products that makes all the difference.
Yeah.
That's where we come in. We need manufacturers, but we need the techniques. We need the products, but we need the best techniques. And this is our vision. If we can combine these, and Mike and I feel like there's common ground here, then we can help every dentist that we teach to start
Yeah.
at the top.
Yeah, no, yeah, absolutely. I always tell every manufacturer, because I've worked with manufacturers and just different companies, that true success isn't, as you mentioned before, isn't the material, but it's the education of using those materials properly, right? So it
Yep.
is that technique, and you can have, as you mentioned before, you're very insightful. You can have great materials, lousy technique, you're gonna have failure. You could have a decent material, great technique, and you're probably gonna have great success. So, but you have to understand how it's gonna work.
And it's complicated because Davey and I have taught dentists in 53 countries around the world. That's a lot.
Hmm.
53 countries is a lot. But there are challenges in every country, politically, militarily, economically, everything. I mean, there are cultures that are different. That's all we can say. But the dentistry is surprisingly the same.
Correct.
And
Yeah.
that dentistry, some of the, I mean, you know, uh, I'm 75. I'm close to death. This might be my last lecture. I'm so glad to be giving it with Mike, my friend. But in the world, dentists have a unique place, and they have a trust from their clients that I don't think AI is ever going to take away. I mean,
Mhm.
it's like AI cannot fix your tooth. Can it give you information? Yeah. AI is stealing my lectures all the time. The only problem is they can't mentor you. In other
Mhm.
words, if you ask AI, it's only as good as the material that they've stolen from somebody. And we're putting the word out that the information that gets taught in biomimetic teaching has a scientific foundation. And that scientific foundation has to be understood by a human brain because it
Mhm.
has to be integrated. One of
Mhm.
my mentors, John Coyce, was an expert on occlusion. That's lesson 6. I
Mhm.
use that information every time I fix a tooth. But all of these areas have certain experts that have had certain successes, but that put it all together and to simplify it, it's like that's our purpose. But if you oversimplify, then you create chaos because dentists, being human beings, tend to skip steps. And if you
Right.
have something that is critical that you skip, you're not going to have the same results.
Yeah, correct. There's another probably Ron Jackson. I don't know if
Oh,
you
yeah, I know Ron Jackson very well.
and he and I would banter back and forth because a protocol might have a lot of steps. And I'd say, well, it's good, it's fine to have all the steps, but then you have error by omission because there's too many steps. So, it's always trying to find that balance of what do
You
we
know,
need to do? Yeah.
I'm glad you brought that name up because I haven't had contact with Ron Jackson for years. He used to teach at LVI,
Right.
and I knew Bill Dickerson well because we went to school together. But Ron Jackson, when he came to Utah to lecture a few times, I'd connect with him. I took a course with him at the ADA convention, and man, this would have been 1998 in Washington, D.C. Anyway, I've always felt like the strongest thing that Ron ever had was he actually had a private practice in Northern Virginia.
Hmm.
Now, that is huge. Because if somebody's in private practice, that's where the rubber meets the road. That's where you get the best feedback. And Ron always had that, even when he was associated with LVI. But yeah, another pioneer
Hmm.
of bonded inlays onlays.
Yeah. And you know what? Going back, been mentored by some great people like Graham Milicic, and then the 90-second crown. Uh, Great wisdom there. But going back to, I think the reason why I'd recommend people that really want to understand adhesive dentistry seeking out like the advice that you have is you're absolutely right. There's a lot of free knowledge out there, but that free knowledge doesn't come with the wisdom or the experience. And that's really what you need. And that's what you're saying AI can't replace. So we'll talk about it later, how people can learn more. But that's why, as we're going through this today, if people hear ideas that kind of resonate with them, that makes sense, then I'd recommend that they seek you out as a great mentor, who's somebody. Dr. Alleman referred to Davey. Davey's his son who works in his practice, and he too is doing a lot of research on the biomimetic approach and the different materials and techniques. So the two of them are a powerhouse of information. And you're absolutely right. Clinicians that have worked their protocols, have worked on patients, and have seen things either not work or work, and then they modify it to have great success. And then you have to figure out, okay, now you have that great success. How do you simplify it so I can teach somebody else to do it? So it's a true art. It's a true art.
Well, and that's why I believe, and I really do believe, Mike. I mean, obviously you have a business and we have a business, but I believe these two businesses, if we can really get the common ground that can be the wisdom from everything we've experienced, then that is something that no matter what you pay for it, it's worth it. And because the educational system is not cheap,
Hmm.
I mean, there are dental schools where you can easily come out $500,000 in debt. Easy.
Yeah.
Well, you're going to pay that off because you're going to be a dentist and people respect and trust the dentist, and you're going to have a business that is profitable. But if you have quality on your side, that's the best marketing that any private practitioner can have. It's called internal marketing, where you treat one patient, they have a good experience, they
Hmm.
tell their friend, that friend comes into your office. It doesn't cost you anything to get that kind of marketing, but you have to create the value by having a product that is really better. It gives you a competitive advantage, and that's what Apex and the Alleman Center.
I think that's great. So yeah, we've covered a lot. But maybe we could jump back because one of the products that Vista Apex now kind of overseas is Ribbon. And
Yeah.
Ribbon, I first started using Ribbon almost decades ago. You had the little box that's always on the shelf, and you always knew what box that was.
That means 10 years, 20 years. All of these things really are the accumulated experience. But when I heard that Apex, which a company I knew from John Kanka's
Hmm.
experience, when they acquired Ribbon, my antenna went up and I'm going, man, I think this could be a good connection because I want to promote Ribbon, not because I've made money from Ribbon. They've provided us few bobbleheads that
Yeah.
they like me to distribute around the world. But the idea is that Ribbon is not something that anybody understands unless they've studied the literature.
Hmm.
But the scientists who produced the literature on Ribbon, since 2002 was the first time I was introduced to it, all of a sudden they were making some claims that could be either verified or nullified, and whether you to put a post in.
Hmm.
I mean, I haven't put a post in a tooth since 2002, and I've had no catastrophic root fractures in any of those teeth. Zero. Thousands and thousands. And I've taught tens of thousands of dentists not to put posts into roots. Now, in dental school, you were all taught to put posts in roots. And at one time, that was the best that we had. Cast posts, that was like, what was the red stuff that we used to use to get the impression for the cast post?
Yeah, the Durlay.
Duralay, Duralay. There isn't anybody listening to us, Mike,
Who
who
knows
has
it?
any idea what
I know.
Duralay is.
I know.
But that was the best we had when we were in dental school. I was at UOP from 1975, 1978. It's the best we had, and we did a lot, and we had success. But when they failed in a very catastrophic way.
Catastrophically, yeah, yeah.
Yeah.
Well, in talking about that, I was talking to the group I was with, the mostly younger dentists that, when I was going through dental school, we were taught to do composites only on anterior teeth. We were told not to do it on a posterior tooth, and if we got the etchant on the dentin, they'd fail us right there because
Right.
that's the tooth is dead after that. So
You got to cover the dentin with Dical.
Tycal, that's right, yeah. And so that's we've come a long way since then, but thankfully, because of work like you and the other thought leaders that kind of kept pushing the idea that no, it could be done and it could work. So it's really exciting. So,
It is.
yeah, going back to ribbon, well, let's hit that because you hit a great topic. You have a tooth that needs a post, traditionally needs a post.
Mhm.
Are you using ribbon as a post or using ribbon to reinforce the crown area or?
Yeah, so here's the concept. So in a biomimetic idea, you have dentin replacement versus enamel replacement.
Mhm.
So obviously, if the tooth has had an endodontic treatment, everything's surrounded by dentin. So what's going in the place where the pulp used to be is considered part of the bio base, which is composite, but fiber in composite has a stress relief characteristic. This stress relief characteristic was theorized by myself in 2006 and actually proved microscopically in 2008. But the stress relief is manifest in the hybrid layers that is connecting the composite to the tooth. So in a biomimetic approach, you will become an expert in the hybrid layer. Now, you've all heard of hybrid layer in dental school. You saw some slides and maybe you passed the test, blah, blah, blah. But the science of the hybrid layer is not easy. It's sophisticated. You get on a molecular scale. That's how you connect molecules of something that's not biologic, like the composite, with molecules that's something that is biologic, like dentin. And that integration of the composite resins with the tooth, that's the hybrid layer. But the formation of the hybrid layer is very weak when it starts.
Mhm.
And so that weakness eventually can become strong, but you had to understand how long that maturation took place. Write this down, everybody listen to this lecture, because it took me 7 years to get this number, but I had to modify it with Simone Della Peri. He thought it was 3 minutes. I convinced him it was 5 minutes. But the truth of the matter is, you got 30 minutes. That the maturation from 3 minutes to 30 minutes, you have a different strength of your hybrid layer. And if you're satisfied with the lower strength because you won't have sensitivity at this particular lower strength, that's fine. But the durability of that hybrid layer, if it's going to go to decades instead of years, and you don't want sensitivity or a gap forming, then you have to be focused on the maturation at a certain level of that hybrid layer. And that number, you can write this down on your arm right now. If you like tattoos, you just put a 50 here,
Yeah.
and then you put I tried that's probably backwards. I'm sorry.
No, it looks perfect.
They're part to understand. But if you had a tattoo that said 50, 30, and 15, then on sound dentin, superficial dentin, you get 50 as a potential. In inner caries, dentin that is slightly affected, but if you have deep areas of dentin, you really only get 30 in the root area because it has more collagen and more water. But if you get between 30 and 50, you have the connection, the cohesive strength, the tensile strength of the natural tooth. Now,
Mhm.
this 15 is only the strength that you use if you have caries dent that you're sealing as part of an indirect pulp cap, and that's something else. But those numbers of 50, 30, and 15 have been repeated in many universities and every. But those strengths of adhesive dentistry, if you know those and you have those, then you don't need resistance form or retention form anymore. There's
Mhm.
no mechanical need to hold the filling or to stabilize the crown. Fillings that get held, that's mechanical. Crowns that are stabilized by a ferrule, that is a mechanical cutting of the tooth structure to make sure that the crown doesn't rock more than it needs to.
Mhm.
We don't even have to think in mechanical retention terms anymore. Retention form or resistance form are part of the history of G.V. Black and all the great prosthodontists that have done great crown and bridge over the years. But adhesive dentistry is our retention form. Adhesive dentistry is our resistance form, and Ribon contributes to that greatly. Um, but you have to understand how to use the materials and the basic materials you have. I mean, Apex has some good bonding systems. I know John Kanka,
Hmm.
worked a lot and taught a lot on that, and they have composites. And now that they've got Ribond, now it's like all they need is to spread the word. We just need to get the word to you guys to buy these materials and then use them the right way. And your patients are going to have the best dentistry that anybody can provide around the world.
Yeah. Yeah. Well, I think I love all your answers because, like I said, when I was answering this group and I said, I think we're over-treating our patients, it's because we think very traditionally. We don't think of all these conservative ways that if I were to have my teeth worked on, I'd want to be treated as conservatively as possible, not have everything ground away because it probably isn't going to grow back. So, no, it's great advice. So let's go back. So Ribon, the obvious uses for people that have used it before to reinforce your directs. Splint teeth that are wiggly, we use that all the time, which is great. Crown, if you're missing a single tooth, you can use it to temporize or create a bridge that I think very, very many times looks really nice. What are some, and we talked about this maybe to reinforce the tooth. You might use it as a post, maybe not, but you could shove it down a canal. And I say it creates like an asymmetric post, less likely to rotate
It's
out
a
if you
custom post. The
custom post.
custom. You
Yep.
don't have to take away any tooth structure to make a post fit. If you have a narrow post, a narrow pulp chamber, and a wide pulp chamber combined, some bicuspids are like that. You got a pulp chamber, it's smaller than you got the root.
Hmm.
In a single rooted tooth, obviously that's very narrow. In a molar, you have, your pulp chamber that is, but all of those, the ribbon allows you to adapt it to any shape.
Hmm.
And that shape not only has a strong bond using ribbon, but it also has fracture resistance. So it's been tested that if you have a failure in that buildup on an endodontic treated tooth, it won't ever fracture a root and it will stay sealed because the top of the tooth can fracture at a lower strength because a ribbon creates a tensile strength of about 20 megapascals. And so if you have, I mean, the complications of understanding all the details of a biomimetic restoration are beyond this lecture, but basically, if you have something fail, you'd like the restorative part to fail and not the biologic part. So
Right.
we don't want to allow any reinfection, and that's what Ribbon guarantees. So we've done millions of teeth in the network that we established using Ribbon posts. Never have had a picture of one that has had a gap that it's allowed bacteria to reinfect the root. Where in the post ways we had a lot of failures under crowns and posts, didn't we, Mike? Back in the old
Right.
days.
And so what are some I'm going to challenge your imagination. So what are some other uses besides some are there any other indications where you used Ribbon and gotten creative since you're the master with Ribbon?
Hey, that's a good one. So the best one are on anterior bridges. So
Mhm.
anterior bridges, I've done a three ponic anterior bridge with ribbon. Um, Posterior bridges, I can tell you right now, do not use ribbon on posterior bridges.
Okay.
How do I know? I've tried it and they've failed. So you just don't have to worry about it. But what's the difference? Mike knows occlusion very well. If you have 10 times the forces on a second molar that you have if you have 20 pounds per square inch here and 200 here, guess
Mhm.
what? This is the place where you're going to have the extreme that it's not going to be um, the the best way to do that. So all of my posterior ribbon bridges, 3 to 5 years, they're gone, and we did either implants or nothing. There are a few cantilever bridges techniques, but that's another thing. But on anterior teeth, I have never had a catastrophic failure on an anterior ribbon bridge that can be done in one appointment, and you can make ponics very well. There is a combination between a glass fiber material that is called Everstick Net, and that with ribbon has some options. And man, I'd love to do an advanced course on anterior bridges with you, Mike. That would be
Yeah.
fun
Yeah, that'd be
because
good.
a patient comes in, they have a number seven that had a crown and it's broken off at the gum, and they've got a
Hmm.
wedding tomorrow.
Hmm.
I mean, that's a real. stressful situation. But the idea is that a missing front tooth can be replaced in one appointment. And if you were missing two, and I've done a 3 unit bridge that failed, and all of a sudden we had a 4 unit or four ponics that I'm
Wow.
restoring, and we did that in one appointment, and it was a permanent bridge for him. Now, permanent doesn't mean it's not going to fatigue or it's not going to chip. When I
Mhm.
mean permanent, we never had to work on the abutments. We had double abutments on both sides. We have four ponics. Over the years of 15 years, we had some chipping.
Mhm.
And where he lost a central incisor, we had some recession of the gum, but he didn't have a high lip line. I mean, we were able to patch this for 15 years, the rest of his life, and he was very happy with the outcome. But, that's something that's down the line. And,
Yeah.
once you're understanding exactly how to do immediate dent sealing on an ideal caries removal endpoint, understand to diagnose cracks and take out cracks. I mean, all the things you have to do to make sure your two abutments don't fail. But then these are some of the things that, personally I've had, and we've taught these to our praxis-based research network. But yeah, I'm glad you asked that question because hey, we can talk. But anterior, especially lower anterior, I mean, I've done several lower implant failures, which I mean the bone is so
Yeah.
spindly down there. The implantologist is taking a big risk unless he does, comprehensive vertical grafting, which can be done, but it's not for amateurs.
Yeah. Yeah.
But
Yeah.
the idea is that these failures happen, and then we put a rib on bridge every couple of years. Maybe we have a little polishing or a little chipping, but they don't debond. That's the main thing.
So I have one more question, and then what I'd like to do is really ask you, how do people learn more about this? Because I think these concepts are great. So let's say we're doing let's say an upper first molar, tooth number 14, the 2-6, and it's got a large MODBL amalgam, right? And it
Gotcha.
comes in, and it's an amalgam, so it's been there for 20 years. Now the margins are starting to stain. We started to see little cracks running through the tooth,
Right.
but still asymptomatic.
Hmm.
What is again hypothetical? What is
No, this is good. Let me just take you through step by step. And so take your notes. You can learn all of the 6 lessons in the next 5 minutes. So the first thing
Okay.
you have to do is say, is this tooth at risk for fracture or decay? And like you say, just looking on the cavo surface, you say, yeah, I see some microfractures in enamel. I see some staining. It looks like there's, so you ask the patient these three questions. Do you have any sensitivity, or can you remember having sensitivity on this side of your mouth to sweet, cold, or biting? So, sweet, cold, and biting are the symptoms that say there is pulpal fluid movement, and that will be associated with deep decay, with cracks, and also with gaps underneath restorations. And the potential for redecay is there. So, if you ask them that and they say no, you say, can you ever remember in the past of having that? And if it's a man, they will say, oh, yeah, but it went away. And then if it's a woman, they'll say, yeah, but it still comes and goes, So, but the
Yeah.
idea is you're making a risk assessment that this tooth is not keeping biologic infection or crack into dentin, which is also a biologic infection, um, out of the future of this tooth. And so, if the patient is proactive and you just have this discussion, you say, do you like to get your tires changed before they blow out or after they blow out? And almost
Right.
every patient will say, yeah, I like to change my tires before I have a catastrophic failure that may cause life and death. I'm being a little facetious, but the truth of the matter is, if a patient is proactive, they understand that doing things early to prevent worse outcomes is a good way to live your life. And so once you have a proactive patient, you say, it's up to you, it's your tooth, but you can chip in. You say, if this was my tooth, I would want to see exactly how deep the cracks are, how deep the decay is, how deep the restoration is, because it takes different strategies to fix this tooth now in a way that can last decades or maybe even be permanent. When you had this filling done, the dentist did a good job, but he didn't have the tools that are now available based on the science that allows us to fix a tooth one time in most cases. I mean, that's as good a sales pitch. And if the patient says, no, I don't want to do it, it's just whatever my insurance will pay for, I'm just being funny because it's a little bit, every dentist lives with patients who are
Yep.
trying to nickel and dime them. But if a patient wants quality and longevity, that's called value oriented.
Hmm.
And so patients that want value, they don't always buy Lamborghinis for some reason. Even if they can afford them.
I
It's
know.
like they're buying a Honda, a Toyota, or a Hyundai, right? Or a Kia. Those are the four big ones right now. Like they go for hundreds of thousands of miles. And that's the kind of thing. But anyway, then when you go, so the patients decide, let's restore the tooth. And then the first thing you do is you isolate it. And then you isolate it with a rubber dam, and then you have magnification. Now, magnifications can be with loupes or a microscope. I've been using a microscope for 25 years. We have three operatories. We believe it's your fastest track to good ergonomics. You don't get back pain or neck pain by doing this. But
Hmm.
the microscope companies, they don't pay me, but we're lecturing in Hawaii in November if you want to come. The big microscope, American Microscope Enhanced Dentistry Academy is putting us on the stage in November. But the idea, you have to have magnification. So whatever you had in school is not enough. Davy had six in school. And the person who sold him the six loupes in school said, I've never had anybody ask for six loupes. Says, why do you want six loupes? And Davy, freshman dental student says, I want to see better. And the
Hmm.
person selling the loops go, yeah, I guess that's why you would buy two power loops or three power loops or four power loops but you need to have six to eight to really make it a real efficient checking for your caries, and you'll be using the technologies of caries detecting dye. And then once you understand how to use that, then you can understand how to dissect cracks in the same manner in the same area. And then you start with your rebuilding the tooth from the bottom to the top with first you deactivate what are called MMPs, and then you have to condition your smear layer with air abrasion or with an acid etch step. And then you have to use a good scientifically based bonding system for immediate dentin sealing. Then you have to do a 0.5 millimeter resin coating, and then you have to be careful not to get thicker than 1 millimeter in the next 5 minutes. And then after that, you take an impression, have a lab do a good job of an indirect composite restoration or Emax restoration, and then
Hmm.
you adjust the occlusion. But all of those six steps have there's details, obviously,
Yeah.
and the details you can learn by learning in a biomimetic system like ours. There are others that are available, and we've been through them all. We've actually created most of the
Yeah. Yeah.
key opinion leaders have learned from us, and now they're teaching other dentists around the world. But yeah, we would really invite you to look into just go to our website, Alleman Center, or Instagram is basically the social platform that I use the most. So my social Instagram account that you can reach out to me in a direct message anytime is david.alleman.dds. Not to be confused with my son who's a DMD. So he's
Yeah.
into tooth healing. I was into tooth surgery. So
Yeah.
Davey doesn't like surgery. I love surgery, but I don't do very much. Anyway, that's our summary, our sales pitch. We really appreciate you giving us the opportunity to come, and we hope this can be the beginning of many interactions.
Yeah, no, I'd love to bring more information to those that are watching this. Really appreciate your time and really want to thank you for everything you've done in the decades of your teaching and
Yeah,
just,
it is decades. I was like, I'm into my third decade, seriously, and 30 years out of 70 that's a chunk. But,
yeah.
I mean, every one of the dentists, I mean, very specifically, if they listen to this, I want them to think in these terms. I'm going to be a dentist for 40 years.
Mhm.
There are many dentists, I mean, not a small percentage that don't like to go to the office, but they go because that's their job and that's how they make money. And,
Mhm.
they do what they do. But I talk to dentists who have that frustration of not having a predictable system, of not having the ability to have confidence that this is going to be the outcome of this filling or this crown or this restoration. And all of these questions were the frustrations for me for 17 years, because after 17 years of doing the kind of dentistry that is taught in dental school, I was so frustrated that I quit dentistry for 6 months actually.
Uh,
But then I discovered through another dentist, Ray Bertolotti, and I went to a 2-day course from Ray, and all of a sudden I thought, man, there's a chance the dentistry is going to change with this new concept of adhesive dentistry. And so
31.
I'm now into 31, 32 years of being under the influence of adhesive dentistry and being captivated by the science. And I've been I'm an expert in the published science, and in our business we have 7 people that work, and 2 are not dentists. My daughter and her best friend run the business end, but the other 5 are all experts in clinical and scientific dentistry with master's degree or PhD, and published articles in very important information in important journals. But all of this is integrated into the whole world that Mike's part of this growth and fundamental understanding of the science of adhesive dentistry. And right now I only see blue skies on the horizon. I hope that's not my death and going to a better life. But the idea is that around the world, when dentists hear about there's a way to make something better, they're interested. But the idea of making it better, but by making it more like the actual tooth, which is biomimetic, mimicking biology, mimicking the tooth, that is a concept that really resonates. It resonated with me when I first um, formed the concepts that we teach. But at every step of the way, interactions with leaders like Mike have given more confidence because they have success. John Kank has success. Ray Bertolotti has success. John Coyce has success. Frank Spear has success. Everybody that's had success in adhesive dentistry um, has benefited from it. And the
Yeah.
more you learn, the more success you can have, and the more teeth that are going to be healthy and last longer. That should be our goal.
Yeah, no, absolutely. Well, like I said, this isn't going to be our last time of meeting and bringing a program and sharing this information, but thank you very much. And to everybody who watched, come back again. We'll see
All
you
right. See you
next
next
week.
time.
Yeah, right. Thank you.
Thanks, Mike.